The video series Cardiovascular Disease was developed by the Georgia and Oklahoma Academies of Family Physicians as part of the Go Diabetes Initiative. The Cardiovascular Disease series consists of 6 video vignettes, each outlining best practices in the care of diabetic patients. Please proceed to the registration page for more information on the approved number of prescribed credits for this activity as assigned by the American Academy of Family Physicians and AMA PRA Category 1 credit as assigned by the Georgia Academy of Family Physicians. Upon completion of each video vignette, please return to the Resources video page on the Go Diabetes website to complete the activity evaluation and earn your CME. This activity is supported in part by an educational grant from Sanofi Aventis. We thank you for participating in this online activity and hope that it serves as a valuable educational tool.
Just to kind of wrap it up, a couple mind discussions. 60-year-old type 2 diabetic on metformin, insulin, lisinopril, A1C 7, blood pressure is 155/82, a little bit elevations in the microalbumin, LDL is definitely up at 150, HDL is low at 36, creatinine is borderline at 1.3, triglycerides 182. What do we do to reduce his cardiovascular risk? Yeah. So he's on diabetes meds, both metformin and insulin. Does anyone have a problem with his diabetic regimen? Not really? Okay. That, his kidney function is still hanging in there, so no absolute contraindication for the metformin or the glargine. Lisinopril, anyone have a problem with that? Not in particular. Got to kind of watch the microalbumin, but that's okay. So you look at his blood pressure still being a little out of control. What do we want to do about that? Thiazides, other options similar to that. And then your cholesterol. That at this point in that particular demographic, in a 60-year-old patient, a statin would be the preferred route. You could argue for the niacin options, trying to raise his HDL, but again, keep in mind that that's going to potentially raise your blood sugars a little bit. Although his A1C is fairly controlled at 7, that it's not going to be a big jump if you add something like niacin. We could be talking about maybe 0.2 of a point kind of range. It's not huge. So those are certainly options. And then aspirin. That he has high blood pressure, he's 60 years old, no obvious contraindications, that he is somebody that should be on at least 81 milligrams of aspirin a day. Next one is 65-year-old type 2 with resistant hypertension. Blood pressure 162/86, pulse is 55, that's worth noting. Weight of 225, he has gout and chronic kidney disease, which we'll come back to why that's pertinent. Meds include ramipril, atenolol, amlodipine, metformin. Labs have a creatinine of 1.8, also worth noting. His A1C is controlled at 6.8. What would you change? Stop the metformin, why? Creatinine, So we stop that. The blood pressure is still up, but his pulse is low. You can go around with a pulse of 55 as long as he doesn't stand up too quick, I guess. But you got to watch it. The point is you certainly can't add any to the atenolol. Diuretics are coming from the back. There's your problem. The gout. So why is that a problem with the diuretic options? The thiazides, exactly. And so, this is the kind of situation where you see all the time. I mean, these are not isolated events by any means. This is just a guy with gout and some chronic creatinine issues, which a 65-year-old frequently has, and his blood pressure is still high. So you start having all these problems. You can add more to the amlodipine to compensate for some of the changes. Once you start getting up around 10 of amlodipine or Norvasc, you start getting more incidences of peripheral edema at that rate. Can't add the atenolol. The ramipril, you got to really watch that. And the metformin, you got to chuck. So you got to replace that with another option for the diabetes while being real careful in what you add for his blood pressure. So you could try something like a spironolactone or other options. You could try the clonidine, which I really hate for chronic management, but you've used the patches that can be an option. A lot of times the people that are on dialysis or renal failure, you're kind of stuck. I mean, you're focusing on beta blockers primarily at that point, and then calcium channel blockers, and very frequently the next thing you go to is depending on their level of kidney function, is clonidine-based derivatives. So it's all just for thinking. Again, there's no specific right answer. And then we've actually had this slide before, and we already talked about the niacin, so I'm going to just bypass that. And then finally, a 32-year-old African-American male presents for an evaluation of poorly controlled diabetes. Diabetes was diagnosed after presenting in DKA at age 22 during rehabilitation from a motor vehicle accident and spinal cord injury that ended his football career. Medications include 70/30 insulin, 65 units BID, family history, early vascular disease, reasonably tall guy at 70 inches, 245 pounds, blood pressure 162/92, pulse of 102. He's got an A1C of 8, so not controlled. Cholesterol 245, not controlled. LDL 165, suboptimal, especially with his family history. Triglycerides 190, HDL's too low at 30, elevated microalbumin. What do you do? You know, you just refer him to the inner city residents. Insulin sensitizer. Statin. And aspirin. So he's 32. Everyone okay with the aspirin option at 32? It's debatable. Yeah. He's got hypertension, clearly diabetic, not controlled, strong family history, that I would support an aspirin use despite his age under that circumstance, as long as you discuss the risks. You know, what's not included is his creatinine, but certainly a thiazide would be appropriate under that circumstance. And the sensitizer, of course, is to try and decrease the amount of insulin that he's using, because 65 units BID of 70/30, you know, again, assuming that the kidney function is okay, you would certainly want a sensitizer like metformin on board.